I'm Mike Kelzer. Growing up in my family's pharmacy, life moved fast. There was always something to do, someone to help. But the moments that meant the most to me as I think back were the conversations my dad and I would have about business and life itself. We'd get so absorbed. We'd talk for an hour and it would seem like 15 minutes. This podcast is my way of keeping those memories alive. There's no scripts, no outlines, no fluff, no hidden agendas. It's just real honest talk about the business of pharmacy and sometimes a little more. Let's dive in. Jonathan, introduce yourself to our listeners.
I'm Jonathan Ogurchak. I'm the founder and CEO at Stack, a pharmacy software technology firm. I'm also the co-founder and CEO at Zeal Specialty Pharmacy, both based in Pittsburgh.
There's two areas in the country that I sort of call the Liverpool of pharmacy, and that's Ohio, I think, and also Pitt. I've had Gordon Vanscoy on the show, and I know that Pitt has brought back a lot of successful pharmacy business people back into the program. Jonathan, I know you've got associations with Pitt. I know that you teach or have taught there, and I know that Panther RX is the logo, the mascot of Pitt being a panther. I know you spent some time there. So you're part of that Liverpool crowd, I call it, from Pitt.
Yeah, absolutely. And, specialty really got a lot of its originations here in the Western Pennsylvania, Pittsburgh area. I was fortunate to spend some time at Panther. Even though I'm not a grad myself, I went to Duquesne up the street to go Dukes. I've actually been on faculty and I've been teaching through the University of Pittsburgh for a number of years. I helped to build a specialty pharmacy track as part of their master's in business administration degree curriculum. And they both hold a near and dear spot to me. But it's neat. You refer to it as the Liverpool. There's so much in this area as it relates to not just pharmacy, but specialty pharmacy in particular. Where I'm sitting right now, if you kind of draw a circle around it, you go an hour and a half, hour and 45 minutes in any direction, I see presence from about 20, 25 different specialty pharmacies. And it's not just, because people were here and they stuck around and they didn't want to move, things like that. There's just a lot of richness and talent in this area. And it really affords opportunities to continue to grow the basis for what goes on in this pharmacy sector. The reason why I never left is because there's so much opportunity here that you don't tend to see in a lot of other locations around the country.
All right, Jonathan. So I run an independent pharmacy in Grand Rapids, and whenever I talk about specialty now, anything that I know the PBMs touch, I can't help but lambasting them and including them in all my griping and bitching about stuff. I know it's not fair to the specialty profession, and I'm always thinking about the opaque PBM when I say this. I'm always saying specialty just means that they're treating themselves specially by taking the drugs that get the profit and giving us pharmacists all the crumbs and things like that. Now, I've had some people on the show, and we've talked about specialty and the reasons why manufacturers might want to have their products only in 4 pharmacies across the nation, then try to have 20,000 pharmacies, making sure they keep the temperature correct and all that kind of stuff. So when you hear someone like me griping about that, I imagine you can see both sides. Being in the specialty profession, you can see a lot of the good, but being sort of a independent person, I mean, not wearing the hat of one of the big 3 PBMs, I think you could probably understand where this darkness in my comments come from. I imagine you see both sides of that from specialty.
Oh, I do. And a lot of times when people say specialty, it's just another S word that gets a bad rap.
That's right.
And I think it's just a function of how it's been steered for so many years. When you look at dispensing in the specialty sector, about 70, 75% of all specialty fills go through one of those big 3 PBM. And it's a function of how the industry grew and evolved. But really, if you do it the right way, and you do it the way that specialty is intended to be, it's not intended to be a glorified mail order. Unfortunately, because of a large volume going that direction, that's kind of the rap that it gets. When you look at even specialty at its core, when it started back here in Pittsburgh, almost going on 40 years ago, it was designed to help manufacturers have the best outcomes for their patients, whether it was through new HIV drugs coming to the market and making sure there was a supply chain to roll patients into the mix, or whether it was new solid organ transplant drugs, getting them to the right patients at the right times for the right doses, and helping with adherence. Those are the things at the core of what specialty is intended to be, that tends to get lost when you start to think of the S word side of specialty. Honestly, as an independent specialty owner, we don't have that affiliation with a PBM. And oftentimes I feel like we're fighting uphill.
Absolutely.
The same way that somebody would be in the traditional community sense, saying, well, here's a patient that's come to my front door. They have a need. It's something that I know that I can fulfill. Why can't I do that? It's a similar argument that we tend to see often ourselves. We've gone through the paces. We've done all the boxes that needed to be checked. And you're still not saying that we're up to snuff for what it needs to be. It makes it a little bit of a frustrating sort of piece. I was listening to one of your shows recently talking about pharmacy education, and specialty tends to not be included in that. And it's the nature of standards work and trying to grow curricula geared towards helping students to pass the NAPLEX. While there are some of those more specialty, quote unquote, disease states on the boards, that's not as much as what you'd see in a community setting or a hospital setting or things like that. So you don't teach to it. And I think that all of those things kind of mush together. It makes this whole area of specialty like a very gray area. Even when you look at things like CMS guidance, there's not anything specific. That tends to be like the gospel truth of how a lot of other plans align. You don't see CMS saying this is what is specialty and this is what is not. It's up for a lot of interpretation. Because there's that lack of specificity, it allows some people to go to one extreme and say everything's specialty. It allows some other people to go to the other and say, nope, we think it should be open. Really, I think what it comes down to, or what it should come down to, is the quality of care that you can provide your patients. And how can you do that in a way that empowers the pharmacist behind the counter to speak to those patients in a way that they need to have information provided to them. If I knew that there was one patient that was going to be coming to the counter for that one drug that I only dispense to them once a month, would I have as much familiarity with it as I would my Lasix or my ACE inhibitor or whatever that might be? But you always feel more composed, like you're Googling it under the desk, just so that when they come to the front, if there's a question, you can answer. Specialty is really helping to guide dedicated resources for the ability to provide patient care or counseling to physicians on how to write for drugs, not necessarily something exclusionary from a reimbursement perspective. I feel like it allows for the pharmacist to be prepared and taught the same way that they would, if you were in the community setting and you were asked to step into an ICU and be able to dose appropriately. It's a little bit out of like the day-to-day practice, but when you start to align what practice settings can look like, there is some benefit from, a pharmacist practitioner to be taught and trained to function in those ways. It helps to align those resources where they need to be. And it allows for those conversations to be happening as they should. It doesn't always get that wrapped though, because when you start to see some of those other things that are out there in terms of patients nearing to a certain effect, going to a PBM-owned entity or going towards an entity that doesn't necessarily provide the same quality of care that an independent can, where it tends to solidify that a little bit more.
I know the PBMs don't probably have this power controlling all the airwaves and the marketing and stuff, but anytime the PBMs can obfuscate something and not really define completely what specialty is and kind of take it away from people that are trying hard, anytime they can make it gray, it's better for them, because then they can say, well, we meant this kind of specialty as far as the pricing goes and not that kind. So I'm going to throw it all back on the PBMs, Jonathan. Whenever we have a chance, we're going to beat on the PBMs again.
Well, and I think it's right there with you, to be honest with you. And we'll see how many PBMs are listening to this recording to see what kind of blowback that is. But, I just look at it, case in point, the pharmacy that we opened here in Pittsburgh, we've been open for about 18 months now. And in that time, we've gone the whole gamut of how to credential and license and get payer contracts, et cetera. And we've been trying to do things the right way in terms of, we know that while we might have billed some things under a retail agreement, because that's how we functioned when we started, we now know that as our scope continues to broaden, let's go get that mail contract. Let's go get that specialty contract. Let's get the reimbursement, like as is dictated to us, so that way we could do it the right way. One payer in particular, who I won't choose to name here, but I've been trying since February of this year to get the right contract, because I know that that's what we should be doing in terms of playing by the rules, et cetera. And it's been just round and round and round. And, oh, you need to go talk to this person and talk to that person. And, oh, talk to this first person again. It's almost as though they're deliberately trying to make it difficult. So that way I just throw my hands up and walk away and say, forget about it. And at the end of the day, is that what it should be? I mean, we all got into this profession because we want to take care of patients. We want to do it the right way. Even the traditional PBM market, we want to do it to save money, et cetera. We can do those things, but it doesn't all have to be done by one party for it to be done well. There's other people that, like you and I, that in that independent setting could probably do as good a job, if not a better job, than what is deemed to be correct out there. But when you don't have a seat at the table, even, it makes it difficult to have your voice heard.
In that area, the specialty area, how much of it, for example, in independent pharmacy, it's like, I sure as hell don't have the PBM sending people my way. I'm talking general community, not specialty. I don't have the PBM sending anybody my way. Maybe some physicians, word of mouth. I don't have really any manufacturer sending people my way unless, maybe with some medical equipment that we used to have, maybe one of the companies knew we had something and sent them our way. With specialty, you could have a hospital, you could have a specialist, you could have a manufacturer, you could have a PBM. Where does most of your stuff filter in from? Is it just basic like an independent community pharmacy would be? Or if you have connections, do you have connections? And if not, where does it come in from?
Yeah, I think initially a little bit of it was the connections piece of things. I always get that spine crawling sort of feeling when I think back to the old day, pharmacy is a small world. And it just makes it such like a trite sort of saying. But I mean, there's so many people that I've been fortunate enough to meet over the years that have been looking for different solutions when it comes to providing that type of care. Put a post on LinkedIn, send a press release, and people see, hey, Ogurchak's doing a pharmacy again. Maybe we should reach out and see what that's all about. I've been fortunate as word gets out and we put out a release, or an accreditor puts out a release saying, hey, here's Zeal. They're now accredited as a rare disease pharmacy. It gives us more credibility to the things that we're trying to do. I think the bigger part and where we started to see more of our opportunities has been due to some of the things that we've done from a technology perspective. So I have Zeal as my pharmacy. I have a separate company, a software company that does some different things as it relates to driving patient outcomes and driving data capture and all the things that really, especially pharmacies, can do a really good job at if it was built to scale and there were solutions available to quantify those things. Because we've been able to do some of those activities, it's allowed for some perpetuation of the name out there. We have a program we did as a pilot where, using the software, we were able to drop ship smart scales into patients' homes. For weight titrated drugs, it's easier for me to say, hey, Mike, go step on a scale. I'm going to click a button, have this weight hit a cell tower, and it's going to show up in your profile in real time. Then I say, hey, Mike, how much do you weigh? And in a lot of cases, it's like, I'm going to tell you what I want to weigh and not what I actually weigh. And that's the case. I'm usually going to get underdosed most of the time. And it really doesn't afford you any solutions. And so, because we've been able to do things like that, where it may have started in one particular therapeutic area, and it works, then word gets out there and it's like, hey, have you seen what they can do? Can you try something like this? Or, hey, we see that we could do really customized bidirectional conversations with the patients, and we can really extend maybe what we asked or did during a clinical trial, but now we could take that out to the masses. You could get real world data on what is happening with our drugs or what's happening with the actual patient experience now that it's outside of that sterilized clinical trial setting. The capability to do those things has really allowed itself to grow opportunities. And that's where we started to see more of that word of mouth, not necessarily from prescriber to prescriber, but from partner to partner. Hey, have you seen what Zeal can do? They can take this data and de-identify it and publish it. There's things that can be done that really put that special part back into what specialty is intended to be. I think that's where we've had as much opportunity to grow is the fact that we've been able to differentiate ourselves in terms of how we deliver those types of services as opposed to some of the others out there.
Jonathan, your patient base, is it nationwide? Is it mainly through the mail? Is it local? How do you describe that?
So it's a little bit of everything, to be honest with you. We have our local patient base, our retail counter, folks can come and pick up scripts if they want to, but we're licensed to dispense in all 50 states.
All right. So, Jonathan, you have some of these cool things you've done for your pharmacy through some of the companies like Stack and so on that you have. You somewhat market to other pharmacies, I think. Is it other specialty pharmacies or other pharmacies in general? What's your target with that?
They are two separate companies. We have the Zeal side that's just, it kind of serves a little bit of a test kitchen for the software side. We can try things out. We can build the cases. We can say this is how it needs to actually deploy. We'd market to pharmacies as well. We have two products today on the software side. One's the namesake, which is Stack. It focuses on all things back of the house. So licensing, accreditation, payer contracting, regulatory compliance, like all this stuff that usually you hand a blank spreadsheet and say, hey, Mike, figure out how to keep track of this for the whole company. And if you screw it up, there's going to be a problem. We've built a curated framework so that way pharmacies can benefit from that. And that's across the board, whether it's retail, hospital, community, specialty. We've even worked into the association space. So we can do growth and development of professional associations in terms of programs deployed, educational offerings that are there. It builds an ecosystem where there's a little bit more from an information sharing perspective. The second product is the product we call On Queue, and that's designed to sit right next to the dispensing system in a pharmacy. It can take data from the claim and build that patient experience to make it more holistic. Instead of training a new team member to say, don't forget if it's a Ceremark patient on this particular drug, ask these questions. We have a work engine that runs behind the scenes that says, we know this about these patients. Let's ask the right questions at the right times and create a different tasking to make sure that we're doing the things that we need to be doing. It's always been, crazy to me that there's so much robust data that we could get in pharmacy, but we're relying on systems that are 40, 45 years old to do things with them. If we can see technology that's being used in other ways, let's find ways that we can apply it to take better care of our patients. Effectively, that's what we're trying to do with these offerings. It doesn't matter what type of pharmacy you are. We've now scaled it so it's not just touching pharmacies. It's being used as a standalone EMR in certain cases for different types of clinics, because the cause and effect type of relationship that you can have with the data transcends just what you do in a pharmacy. And if we can find ways that, if this happens, then this is the cascade of events that happens thereafter. There's ways we could get much more standardized, much more robust data and try to do it in a way that it's overcoming that N of one. You see a lot of pharmacies that say, this is not the way that it should be. I'm going to go build my own solution, own little N of one type of scenario where it doesn't play nice across the board. And so you're only as valuable as the data that can be shared in terms of helping to scale and grow these things. You look at other initiatives that are out there that people have been trying for a long time to say, well, let's prove the value of a pharmacist in the community setting. Let's show the clinical things that they could do above and beyond the transaction. But when you're talking apples to elephants and how people capture that data and there's no parity, it makes it hard to demonstrate to scale. And so that's what we're really trying to accomplish, was take the tech that's out there, find ways to scale it and grow it. It's just trying to find ways to take what healthcare data should be and make it actionable.
All right. So Jonathan, here's a 3-layer question for you. Currently, how much time are you spending percentage-wise between the different things? And then secondly, how much time would be good for the company for you to be spending among the different things? And then thirdly, where would you like to spend the time if you had that option? So, where are you and what do you like to do though?
You figure when I left my prior pharmacy ownership role, it was to go start the software company. That's kind of where my heart lives and breathes.
And what kind of pharmacy was that?
It was Panther. I was one of the co-owners at Panther here in Pittsburgh. So when I left Panther, it was kind of multifaceted. At the time, my wife and I were expecting our third, and I had seen how much I had missed because of just spending hours upon hours in the pharmacy to grow the business. I'm like, I don't want to be that dad that's absent. So I want to make sure that I'm there and I'm present for all of these milestones that you don't get back. I was fortunate enough to divest my equity and do those things. But at the same time, it was like, well, I have this itch to do something with technology. So let's figure out how we can build something to scale and scratch that itch, and hopefully more pharmacies can benefit.
Jonathan, when you talk about Panther, were you part of the group that when Gordon tells me this group of students came and talked to him, were you one of those few people?
So I was not one of the original Panther guys. I had worked with one of the other gentlemen. In my early days, we worked at Accredo, which is Express Scripts specialty pharmacy. And so
yes.
I had kind of grown up in the Accredo world, and I was going to take another position at another specialty pharmacy. They convinced me in the meantime, like, hey, you've built the operations here. Why don't you come do that for us at Panther? So I was hire number one, really, as a pharmacist that came in and helped to build and grow. And then, over time, I was afforded the opportunity to buy into the ownership group. Part of me thinks is why they had me teach at Pitt, just so they could say, hey, he has a Pitt connection, that she's going to be a part of the Panther side of things. I wasn't one of the original few, but I came into the fold after we kind of grew from the garage into our actual facility. I was able to join and be a part of it.
You kind of moved away from there into the technology computer world on purpose.
Yeah. And it was one of the things I even swore at the time, like, oh man, I'm never going to open a pharmacy. That's crazy how like throws curveballs at you. And here we are today with another pharmacy. But, at the time, it seemed like there was, and there still is, a huge opportunity as far as what can be done with technology as it relates to outpatient care and the care that pharmacists can deliver. When you see case studies that look at the value of care, you're looking at real world outcomes, a lot of times you don't see pharmacists as part of that conversation because there's a lot of disconnection between how that data can be quantified as opposed to, let me look at something transactionally. A patient had a hip replacement, they were back in the hospital and they weren't. When you then start to scale it out and say, well, here's Mike's pharmacy and here's Jonathan's pharmacy, and here's how they're capturing what they did to keep that patient on Lovenox to keep them out of the hospital, there's not a real standard way of doing that. Or there's not the same standard that we use to bill NCPDP claims. You're not seeing that when it comes to delivery of care and delivery of service. So it's hard to quantify those things. And to me, I think that's where that next threshold is going to be for pharmacy to prove some value. It's more than just a transactional piece. Sure, it's a necessary part of what we do, but what can we actually prove in terms of how there's outcome related to those interventions that we make? And is there a way that we can start to standardize those things, leveraging technology just to show that there's value to including this as part of that care conversation? We know that there is as pharmacists. That's where I feel like as pharmacists, we put our heads down, we get the job done, but we're not out there tooting our own horn for the things that we can and should be doing.
So you leave there and then you find yourself in pharmacy again. If I'm in your shoes, I want to keep doing the computer stuff. I like that kind of stuff. Where do you sit then? So you open the pharmacy. Is your heart still looking to the computer stuff?
You can't serve both masters. There's enough there to grow each one of these opportunities that realistically, should you be focused on one or the other? And really, they're synergistic. They help each other to grow enough. Somebody used the analogy, I had to laugh. It referred to me as the George Lucas of pharmacy. I said, what the hell are you talking about? Like that? And they said, well, no, if you think back to when he was innovating and trying to build these new opportunities to direct movies, the technology didn't exist for George Lucas to make a Star Wars. But then he went out and he built the tool, he made it work. And now you have however many other movie studios that are using industrial light and magic to scale because of that synergy between the two. I would have conversations with pharmacies about putting a smart scale in the patient's home. Their eyes would just kind of glaze over. They'd give me that look like, what are you talking about? How is that something that we can actually do? Whereas now, because we're able to do those things, we can deliver a program like that. We can show how it's built and intended to work because we have the ability to do so through the pharmacy.
What led you back into the pharmacy? You left because of the technology. Why did you end up back then?
A couple of reasons. I think first was the technology piece, because it afforded me an opportunity to show how the technology can actually work and scale. And if we can build some programs, but I think part of it was just because of some changing dynamics in the industry. I kept in touch with a lot of folks from all walks as my career, I would often be asked by folks on the pharma side, who should we go work with? What would be a good fit for us in terms of a pharmacy that we're looking for, a network of pharmacies, or should this go community? Should this go specialty? I answered a lot of those sorts of questions. I think because I've done this for a while, but also because of that educator part of me, I try to keep an agnostic sort of mind when it comes to what the industry should do. What are some best practices, that sort of thing. And finally, somebody said to me, well, if you built the technology, why don't you just build the dispensing part to go with it? And that way we could work together again. And it was like that aha kind of moment where I was like, yeah, maybe there's something to it. And took an opportunity to put a business plan together, and we saw where some of the direction could be. A lot of those referrals that I was making to go elsewhere were things that could be done a heck of a lot easier, especially if we use the technology at the core of what we built at the pharmacy. So we can scale, we could show those efficiencies that were intended to be there from the technology perspective. And we were doing it from the jump. We weren't doing it as an afterthought or a solution that was coming in later on. It's allowed us to grow much more quickly, even on the pharmacy side too. I think where we are today, we weren't anticipating being at this point until year 4 of a business plan. It's largely because we've been able to scale and replicate programs using the technology. Kind of that validating sort of feeling like, okay, well, here's where we thought that something as simple as looking at a call center and sending text messages to patients to initiate refills instead of me paying somebody to sit and leave voicemails all day long. It's that kind of hunch, that hypothesis, that it's going to work, but we can show now it actually worked. So when the sales team on the software side needs to go and make a case as to why, instead of hiring that next call center representative, look at what you can save in terms of cost savings, because there's efficiencies you can gain. And there's not just operational efficiencies, but you can build a better rapport with your patients because of meeting them where they're at from an expectation perspective. I always use the example, I was on a flight this time last year. I was going to speak at a conference, helping a little old lady beside me get her bag down from the overhead. I left my AirPods. Realized that after that point of no return, where you're not allowed to go back or else they're going to haul you on handcuffs type of thing. It was easier for me to log onto Amazon, order a new pair of AirPods, have them shipped to my hotel. It is for most patients to get started on medications these days, and especially when it comes to these higher touch, higher cost sorts of therapies. Why should it be that way? It really shouldn't. If anything, you would think it would be the other way around. It would be easier for people to get the care that they need when they need it. For whatever reason, it never seems to line up like that. So it's become a little bit more personal for me, I think, to try to find ways to deliver that care and allow others to deliver that same scalable sort of care. If we can do it and prove it at the same time, then it's a win-win for everybody.
I talked percentages, and now the question changes to it's very much intertwined. Are you comfortable with that? Are you itching to grow one side more than the other, or is that symbiosis okay now?
I'm being very deliberate in keeping those two companies separated. I think that's maybe just a business decision on my end, but I truly feel as though in order for more organizations to benefit from those solutions, it is better to keep them separate. Because if it's Zeal software and you're going to use Zeal software to go and get better pharma data, it kind of has a stigma associated with it.
Sure.
Even though it's separate, it's Stack's process. I'm still the common thread, but it allows for those things to operate independently. I can have opportunities where maybe a pharma company wants to leverage the technology side to actually administer a limited network. Zeal doesn't have to be a part of that. I'd love for it to be, but it doesn't necessarily have to be a part of that in order for that software opportunity to grow and thrive. It's allowing for the solution to scale and more patients to be impacted by the ability for that technology to grow. On the flip side, maybe there's something that we can do on the pharmacy side. Let's scale it and find ways that we can grow that and make it an offering that's just good for us. There's a number of different ways to look at it. You're talking about percentages. Right now, I try to keep it 50-50 as much as I can. But there's times where it may look to shift up or down based on the needs of what's going on. If we have a need on the pharmacy side, right now we're getting ready to launch a type of drug, probably shifting more towards the pharmacy side. But I also know that I have folks on the software side that are able to allow it to run and grow effectively, where I can focus some of those efforts, and vice versa. If there's something that needs to happen, we're getting ready for a release of a new product or service on the software side, I know that I have a team in place on the pharmacy that's going to allow the pharmacy to not crumble with I have to focus my efforts there differently. So yeah, I try to keep it even keeled, but at the same time, I have teams in place on both sides that I trust implicitly with keeping things running if and when my focus is diverted a little bit just based on the needs of that particular point in time.
What's your worst quality you bring to your organization? Probably my worst quality would be sometimes not relaxing in my mind as much as I should be. I tell my team when they go for the weekend, they'll say, "You need anything else?" And I'll say, "The best thing you can do this weekend is to forget about us, because I want you coming back Monday fresh and ideas and that kind of stuff." And I don't do the same thing sometimes. I wish I would. And I don't pull out papers or anything. It's just kind of spinning up there, and it's not good for the business. And I'm getting better probably. In your case, what's your worst quality you bring as a leader to your groups?
It's that inability to say no. And because there's so many opportunities that are out there, I always find my mind always spinning in that same sort of way. So can we do it? And no, we can do it. It's just at some point there has to be an opportunity cost with one of those options. And I think that I'm trying to get better at that, but I know that there's so much opportunity that there's almost this opportunity frustration to say, well, we know we do this and we could do it a lot better. So let's figure out how to make it happen. We can scale, we can source, we can do this. But at the same time, there's also something to be said about having a little bit more focus and the ability to say no. You're not going to be everything to everybody all the time. And I think that's where I've tried, personally to see, well, how can I find ways to balance when to say no? Because there's ways to fix everything, but you're not always going to be Mr. Wolf from Pulp Fiction where they bring you in to fix things.
I got to see the movie still. I also have to see Sixth Sense, with Bruce Willis and things, that one too. And the nerve of some people to spoil the ending for me. I know it's been probably 30 years, but you think people could be a little more...
You would think that, oh yeah, absolutely.
You think they would realize not everybody has seen it.
But yeah, no, I think that, it's kind of a long way of saying, I think as an entrepreneur and as a business owner, you can always find ways to find your solution to make it fit. And just knowing when the right time is to say, maybe this isn't a good fit. Let's find ways to do that. And I've become much better, especially over the most recent months where I've been having to split more time. Maybe I'm not the solution, to let me find somebody who is and make a referral so that we can still meet the needs of what that other stakeholder has, but I don't have to be the one to always do it all the time.
I've never been one much on mission statements and vision and stuff. And it's hard when you're a community pharmacy, because when you're serving everybody from an infant to a 99-year-old person for every product, it's kind of hard to narrow that. But for example, with the podcast here, I said, all right, I'm going to kind of vision this out, because sometimes you're enamored by the TikTok videos and the quick things, and being the first one on top of some post on LinkedIn or something. I said, wait a minute, now what do I enjoy? I don't want pressure. I don't want to be in the know. I just like the long conversations and going unscripted, honest, deeper than maybe a lot of things. And lo and behold, just by spending an hour on that, writing this out and using ChatGPT to help me with the vision statement, not that I had a weight on me, because this is just fun. It's just a hobby fun. But when you spend that time, you don't realize how many things are vying for your attention out there, that when you find the purpose, it really alleviates a lot of stress, doesn't it? Know what direction you're going with things.
Absolutely. And especially knowing that there can be so many multiple competing priorities at the same time. Somebody told me once, it's okay to have a lot of balls in the air, but you need to know which ones are made of rubber and which ones are made of glass. I've always kind of had that mentality, because especially when you have so many competing priorities, that there are some that you just can't mess up. And there's other ones that maybe you can let it slip a little bit. At the end of the day, it just comes back to your own integrity and what you want to be known for in a marketplace, or personally, professionally, whatever that is. And I think that always kind of comes full circle to drive me forward. Do I really want to be known as the guy that lets things slip and gets it done well, but it's not always a priority? Or is it something where it makes more sense to be able to say no and focus on doing a lot of things really well? I don't know. It's kind of interesting that you say that, because there's so many ways. You read any number of business books on what the right thing to do is. I think it really just comes down to what's the right thing for you at that point in time. You make decisions, you make them the right decisions. Should I have gone and started a software company? Who knows? Should I have opened the pharmacy? You can always have that moment of self-doubt and wonder if it's the right thing to do. But in the moment, you're going to make it the right thing. Knowing the information that you have, you're going to continue to push forward until you have new sets of information, and then you make a better decision based on that. It allows for people to pivot and be more deliberate with how they're working in the day-to-day with those sorts of things.
I think back to business decisions and things I've done, and sometimes I have to just say, well, it was probably better that I was there than wasn't there. But a lot of times you think back and you're like, oh, I should have done this or that. It's like, those were both crap positions. Those were both negative decisions. You had pressures. Now you're deciding between an obvious good and obvious bad. You had two bads, and there was a bunch of bad ways they could have gone. You make a decision, and it's there sometimes that I say, was it better I was there or not? I probably made as good a decision as anybody else is going to make.
Making a decision based on the information you're given. Let's pick a best of the worst type of decision. As long as it's still a decision, it's something that you can act upon and start to move forward from it. I think oftentimes people get that deer in the headlights type of approach when they need to make some of those decisions that are important. Even if you don't make a decision, that's still a decision. The decision not to act, it's still something that's going to guide the next steps of whatever that path may be. And I think sometimes people become too paralyzed in the analysis of that situation to know what they should do. But it's some advice I always give to my pharmacy students too. I have so many students that I've been taking happy students in the pharmacy before. We've done a virtual thing all through COVID. So I think I have like 26, 27 schools that send students my way virtually just to see entrepreneurship, see the specialty, see whatever. Around this time of year where you're starting to get into the residency fellowship type of conversations, and you have so many people, these students that are just getting visibly stressed about this. It's a life event. It's a life event. It's going to have a beginning. It's going to have an end. What I'm doing right now probably isn't going to be the same thing that I'm doing when I retire someday. It's knowing that each of those decisions along the way, whether they're a better of two bad decisions, if one's a good one, if one's not, it all becomes incremental in the process to get you to where you're going to be someday. I know I've made a lot of bad decisions in my lifetime, but if I can use that as an opportunity to learn from it and take a step in another direction, then it wasn't that bad of a decision overall, and I kind of use that as my framing of mind. And I try to, encourage students to do that too. At some point in time, you're going to need to make that decision, but what can you learn from it and trying to get you to where it is that eventually you're going to go? Maybe the student doesn't want to be a staff pharmacist at a hospital for the first job. And if that's the only thing that's available to them, learn from it, take something from it, and kind of parlay that into whatever that next is. Just making those best decisions for yourself at that point in time. And I think that's the case for anybody, but especially for business owners, people that are doing these things where you're making decisions to the livelihood of your business and the livelihood of your family and the livelihood of other people's families that are counting on you for salaries and jobs. You can put a lot of undue pressure on yourself, but making those decisions that help advance to the next step, you can always pivot. Learning from the things you do wrong sometimes is more beneficial over things you do right.
My best friend and I will be sitting around and I'll say, Dave, damn it, I should have done this to so-and-so. I should have fired him and give him a what for back then and this and that. And then we'll be talking and we'll say, all right, well, Mike, let's run back the clock. Tomorrow's going to be that day. Go ahead and do that now. Go ahead and do that thought that you think is so wise now 20 years later. So you go back in that day and you're like, all right. And you're like, oh, wait a minute now. In 2024, I thought I was all badass and I was going to do this from something back in 2011. I forgot, now that I'm back here in 2011 and I have to do this, I forgot I'm going on a family vacation next week. I can tell this guy off, but he might quit. And then I'm not going to go on vacation. And then my kids are going to remember the time that I broke their Disney trip. And then they're going to, it's like, it sounds good 20 years later, like I should have done this, but it's like, you play the hand you're dealt at that time. It's a crap decision sometimes. Just make it and you learn and you keep going.
Yeah, it's the old Marty McFly syndrome. Like if you could go back and change something, would you do it? you never know what that downstream impact is going to be 30 years later. It's hard to predict that future, but making the best decision at that point in time, you got to trust your gut. And I feel like I've made a lot of decisions in my career where I didn't really have a sounding board to bounce things off of, but your gut tells you one thing. And usually when you trust your gut, there's a reason for that. It kind of steers you in the ways that you should be making decisions.
It's your gut at that time. It's not even fair to go back 10 minutes later or the next day because it's a river. Things go by you so fast, you can't hold on to a part of it and say, this decision should have been that. Everything changes each moment to each moment. So it's at the moment where your gut is.
Yeah, absolutely. I didn't think we'd be waxing this philosophical when we were talking here today, but I kind of like it. This is fantastic.
This is what we do, Jonathan.
Having the time to reflect on these things is important because so many times the needs of the day are the most important thing of the time. That's where we see it happening so often with some of our software customers. They'll say, hey, we're going to get accredited and we're going to do this and we're going to kind of let it go. And then we're going to forget about everything that's out there because we have 30 more scripts that need to get out the door and we need to call back Mrs. Smith. We need to do this and do that. And, the needs of the day tend to take priority of all of these other things that you might have committed to. And it's hard sometimes to just take that step back and refocus and know what is the right direction that I need to be doing, not just here, but more broadly than that, because you're just so entrenched in the mentality that you said, go and not think about this place for a little bit. That's what's best for everybody. If you don't think about work for the weekend, it allows people to reset and recalibrate and make better decisions at that point in time too, as opposed to just always being on.
I talked earlier about the PBMs with all the grayness of it. Now, here's a problem in pharmacy with the DIR fees, which are supposed to be gone now. I'm sure all of our listeners know that, but basically in pharmacy, you would sell something to a patient and then like 3 or 4 months later, because of some screwy Medicare law, these pharmacy benefit managers could basically take money out of your back pocket and say, you owe us this from 3 months earlier when this happened. So my thought is that they don't want you to have time to think about these things, because if you and I were a home builder or something like that, and all of a sudden no one wants to build, and now all of a sudden instead of you and I working 60 hours a week, nobody wants to build, and so we maybe drop the price a little, maybe go down to 40 hours, and then you're like, maybe I should spend these 20 hours that I went from 60 down to 40. Well, maybe I should just spend time with my family. Well, now it goes from 40 hours of building down to 20. And now you say, dang, I'm making less money. I'm not working as hard. Maybe now I should think about, is this the right profession for me? Should I sell the business? Should I start building something else? Should I get into this or that? But the problem is, what if you were building these houses and you were still at 60 hours and still building as many houses? You didn't even realize it, but all this money's being taken out the back door. And I think that these PBMs, by taking it out the back, the pharmacist is still running ragged and still filling the same amount of prescriptions, and they don't have time to blink. And so they can't have these thoughts that you and I are talking now. And it would have been great if up front the business went down 50% and they knew they were being screwed. Then they would have the time and the energy once they gained their composure to look at where they wanted to go.
Yeah, and even to kind of play off that analogy, you're talking about building a house. If you're putting a roof on a house and the rain's coming, you're going to be making sure that you're making that decision, whatever, right, wrong, and different. I'm going to put an extra nail here, an extra screw here just to make it happen. And that's what pharmacy owners are faced with. You have a patient on the other end of that phone, the other end of that counter that needs something at that point in time. And you're making the best decision at that point in time to take care of that problem that's in front of you. But in reality, it's months later where they're coming back and they're saying, oh, well, you got to pay for 10 extra boxes of screws that we think maybe you used, but maybe you didn't. And I think as clinicians, many of us are trained to do that assessment, to see what the problem is in front of us, to see how we can look to address and how we can look to make sure that there's an outcome associated with that. You're not always thinking about what the repercussions are. And the way that some of these DIR fees were even derived were based just on that. They're not things that you're thinking about in the here and now. You're thinking about Mrs. Smith who needs that prescription so she can go home because the access fan's waiting outside. Those are the things you're thinking through. You're not thinking of what the downstream repercussions are later on. I think to your point, it's a wish and a knock on wood that these things are kind of culling away. But if it's not that, there's going to be something else. And it's when you look at where pharmacy has grown, it's not getting any easier. You're not seeing regulations go away. You're seeing more of that being put on. You're not seeing fewer terms and conditions going into a PBM contract. You're seeing more of that stuff. And so I think that it's for those of us that want to keep doing what we're doing, we're going to continue to find ways to overcome that. But I think you're right. I think it's a way to start to create these exclusionary pools where, is the juice even worth the squeeze anymore for me to continue doing this? Or start to say, you know what, let this be somebody else's problem. It's created a weird sort of dynamic.
In my pharmacy, if I'm losing money on Mrs. Smith, I'm still going out and listening to her about her grandson, and I'm letting her talk to me for 10 minutes, even though I'm losing money. But we don't do anything about it. You still give them the same exact service. You don't put them at the back of the line. You give them the same service. At our cottage, we're getting some trees removed someday, and as that business starts to go down for whatever reason, you realize that. And it goes down a little bit. And then maybe someone else sees that they couldn't get their tree cut down. And so they start a tree cutting business and they rise up while some other company's going down. And it's just a balance. But in pharmacy, you've got this fictitious high level of service that has no infrastructure under it. And all of a sudden it drops off.
And I think that's part of the reason why I always come back to the technology piece of this, because how many of the things that are being done on a day-to-day basis in a pharmacy, whether it's specialty, whether it's community, whether it's hospital, there's so many processes that are repeatable processes. There's so many processes that are things that, could we have a better, more meaningful conversation with Mrs. Smith if we knew about her grandkids and we had all this information and it wasn't just in Mike's head that he was the only one that she wanted to talk to. If you could build those sorts of things, it allows for the function of the pharmacy to scale and still provide that same level of service if it's done in a thoughtful sort of way. I'm calling the cable company and you feel like you're just talking to a call center. They don't know you from Adam. That's totally the opposite of what it comes to when you're looking at customer service from a pharmacy. Knowing that you could take what you know, what it means to take the best care of a patient, we could find a way to put some technology behind that. It's a win-win for everyone. Could we take Mrs. Smith who wants to talk to you for 10 minutes and take that same level of information that we know and have learned about her, but put it behind a conversational AI tool? So it sounds like she's talking to a pharmacist, but she feels like she's being heard. We're getting that information behind it, but it's allowing the pharmacy piece of things to be more functional. And I think that there's so many people that have said, here's all these solutions that are out here, but maybe there's something in it that actually makes it make sense. There was a program that we had tried to launch going into COVID. It was a program where we were going to deploy it in a community pharmacy. It was based on data that a pharma company wanted to get about a brand product that was largely dispensed to community. As soon as we saw that NDC that was being billed, you would get an email and said, Mikey, it's time to ask these 5 questions whenever Mrs. Smith comes to the counter. You're going to get reimbursed however many dollars for doing this type of activity. But if you don't ask those 5 questions or if something happens, we now know enough about Mike's pharmacy so that way it could route back to a call center. And I could still have that same sort of conversation with Mrs. Smith. Mike's from down the corner wanted me to give you a call. And he wasn't able to talk through this. And it still was allowing that same level of knowledge of what would happen in the community to scale. But that way you were taking the little bits and pieces that you knew and could actually prompt people for to try to grow that. It's taking that corner drug sort of mentality that put it in a call center and not make it feel like a call center. For whatever reason, we as pharmacists and we as healthcare are so stuck in our ways. Like it's got to be this way because it's always been done this way. When in reality, maybe something's worked better in another type of industry that we can apply that to what we're trying to do in healthcare, leveraging technology in the background, and we can now scale our deliverables exponentially and actually scale patient satisfaction. And there's things that can be done, but oftentimes, again, we're so entrenched in the day-to-day of what do we need to do to get that next script out the door, or get that PA approved, or make sure that the copay cards applied. then to take a step back and say, what is it that we really can be doing to make sure that the next time there's a copay card, we have 5 patients that could benefit from the things that we learned just now? Or maybe there's a question we ask about a side effect in the patient. Maybe it's something we didn't know about, or maybe it was something that was less than 2% in the clinical trial, so it didn't show up on the PI. But if we have another patient reporting it, let's find ways that we can kind of scale that backwards. You don't do that with just one pharmacy and one pharmacist that hears that one case report. It's finding ways to use the information you have to pull it together and help empower other people to make better decisions.
I think back to my cousins, my uncle and then my cousins, and they're all like 75, 80 now, but they owned a pretty fancy restaurant. When people went there, part of that was getting talked to by one of those cousins. If I went in with my wife, or someone goes in with someone they're dating or something, they want the owner to come up and make some condescending joke about you, but butter up the lady, all the ways that you can do things to make people feel special. But the problem is these guys were there till like 2 a.m, real late restaurant stuff. And then I remember my dad, he always wanted to be front facing everybody. And earlier in my career, and this is when social media was coming up, and that's like, hey, I'm going to post some stuff from personal. And when people come in the pharmacy, they may not see me, but they're going to see some of that social stuff people still want. I don't know if that really didn't replace it very well. But how do you give what they want on scale a win-win for both of them?
Yeah, and nobody's quite figured out that true solution yet. But I think that there's a little bit of a better opportunity to find that solution when you have the folks like you and I who are in the trenches taking grenades that know what's going on to help drive some solutions, as opposed to, I can't tell you how many vendors, I'm sure you see those 2 vendors come through the door. Hey, here's the latest, greatest, whatever. Well, have you ever set foot in a pharmacy before? No. How's this going to work in my day-to-day? Well, I don't know. We just had some money from Silicon Valley. Somebody said pharmacy was cool. We should invest in it. And I'm going to throw some money towards it. Well, it's only good if it's something that actually can be usable. It's something that could be, applied into the day-to-day. And I feel like too often that's what's being missed when it comes to some new opportunities. It's a really great, technically savvy idea. And usually I'd entertain those vendors when they come in, or I'd entertain them on a Zoom call or something like that. And I'd say, well, tell me how this is designed to work in my pharmacy. And as soon as I get the no, I'm like, well, then what good's it going to do? I said, no offense, but if it's not going to work, it's not going to work. And, until you find ways that you can align some of the technology with what a workflow should be in that healthcare setting, it's just another thing to forget as an outlier, and that's where, if you could find those sorts of ways to integrate and build and do things to support the day-to-day, it becomes a much more usable offering.
When I looked at some of these delivery app things that came out 4 or 5 years ago, and they raised $1 billion or something like that, and I'm thinking, do they talk to pharmacies? Do they know the intricacies of this?
No, it drives me nuts sometimes, because I'm thinking, I actually have a solution that I know works, and I've done this before, and I'm seeing this guy over here raise a Series B, and I could poke holes left and right through the solution. Like, why am I not having that Series B? How much further along would I be if I had that type of capital? And, it makes you wonder sometimes. One is you're talking like, hey, is this something I want to keep doing anymore? One of those like down type of decision points. Like, sure, if you're seeing, there are opportunities out there that are being funded as opposed to, tried and true solution, it just kind of can be one of those factors. It's like, holy crap, am I really doing this for the right reason? Or is it something where it's all falling on deaf ears because I don't know how to go and raise the money that would make it sound sexy to somebody else? I mean, pharmacy compliance, not sexy by any means. I'm the first to admit it, but it's a necessary evil. It's something that most people would probably put 2 or 3 FTEs behind. If you could find ways to offset some of the spend in putting a tech solution in place, why wouldn't you do that? But it's always something that you don't necessarily think of the spend because, in the day-to-day, which is getting done, wouldn't it make more sense to have something like that would allow it to scale and grow? And you could take the personnel resources that you have and put them towards more patient-facing activities. That's not as sexy when you're talking about trying to go and raise capital, but it's a necessary sort of evil.
There's a huge value in a company like yours that's able to combine the problems that you have, the stumbling blocks in pharmacy, along with someone like you who's forward thinking, along with being intertwined with technology. That's a good combination of somebody, because some of these companies, I don't reply to all the people that reach out to be a guest on the show, but I had a guy last week and he looked very interesting. He wanted to come on because he marketed for Caterpillar and John Deere. He works with that company promoting them. So I thought, I'm going to respond and I'm going to tell him why it probably wouldn't work for us. I wrote something back like, pharmacy marketing is unique because we need to market to people, but half the people that come in from that marketing, we don't want to sell to because we're going to lose money. Okay, thanks. And they moved on. It's just a challenge. And so, your stuff and the effort you put in combining actual pharmacy with your products and not only your history, but testing them day in and day out, that's a value that, and I know we're focused more on the fun technology stuff here. It goes both ways, but it's really cool what you're able to do with technology because of that depth that you have.
I always use the example, it's like the old Hair Club for Men commercials. Like, not only am I the president, but I'm a client type of thing. It's one thing if you're selling, hair plug, but it's another thing when you're actually trying to sell things that you need to run a business. If it's something that we can't find value in, and now we can prove that we can, it's great you had that gut feeling, that hypothesis that maybe this is going to work. But if you look at it, it's like, there's a reason why, maybe validate it. But now you can validate it the other way too. My gut is telling me the right thing. There is some value in what we're trying to derive here. It's just getting others to appreciate that value so they could benefit from it as well.
That's where the rubber hits the road with your stuff, because the problems, you can come up with solutions. Like you say, you can test some things. They don't all work, but you're dealing with reality. I know I've got this medicine I need to take at night, and a lot of times I don't take it. It's not because I don't remember. My app goes off. It's like I'm home after work. My mind says I just want to be done with any to-do list, any alarms. The thing goes off at 9 p.m. I'm like, screw it. I don't have the energy to get up and walk over to my backpack and take the tablet out and take it, even though it's going to extend my life and keep me from having DVTs and all that stuff. The point is, you can think you've got all these answers with your technology and so on, but unless it's coming from somebody who's lived it and then sees it and then knows that the simple, maybe logical answer is not always the answer, you're not going to make it.
No, I think back to early in my career, we were trying to put a new solution in place. Oh, this is great. We're going to put a web portal out there, and and everybody wants a web portal. This is the way it's going to be. And then next thing you know, we're primarily dispensing Med-D oncology patients. At the time, the older populations were as tech savvy. So we put all of these efforts into putting the solution in place, only to find that nobody was doing it. We're like, why is nobody doing it? Well, because on their little flip phone with the T9 texting, they can't get access to a web portal. And so we said, okay, great. We'll move it into another patient population. And we're all going to go with younger people. And we're going to focus on HIV and adherence. Well, it was Ryan White's 340B program that was financially underserved. They may not have had access to those sorts of tools. Just because it's a solution doesn't mean it's always going to be the best solution. Oftentimes, that's how these things are being sold. You're going to put this in your pharmacy, Mike, and it's going to change the face of adherence, and you're going to get refills and auto refills. But if it's not meeting the patients where they need to be, it's just another fancy, shiny thing that you're going to have out there that nobody uses. That's part of the reason why I've refused to build any sort of app. So many people are like, oh, do you have an app? Well, who cares if I have an app on the App Store? If it's something that people have to go download, nobody's going to use it. It's cool to say, hey, I have an app on the App Store, but is it really something that's functional? Then no, I'd rather spend money and efforts and energy on something functional.
Exactly. And you'll know what that function is. You're breathing it. And I'm sure, Jonathan, you get maybe not so much because you're coming from the product side, not so much maybe a receiver of a salesperson, but then you always get the, we figure there's 300 million people in the US. And if you just get 1% of 1% of 1%, it's going to be 3 people a day who are going to do this. And then it's like, nah, that math doesn't work out. Either it's helping or it's not helping. Well, golly, Jonathan, thanks for joining us. Nice talking to you.
Yeah, appreciate you having me.
As we said, it's that combination, and you saw it. You went to the technology and saw that bringing in the pharmacy too was going to improve both symbiotically. So very cool. What's the best way for a pharmacist to dabble in what you're doing? Is it to visit you online? What's the best way for them to get in touch?
LinkedIn is probably the best way for me. I encourage people to reach out to me directly on there. You have to type the whole long name to find me. It's part of the challenge. If you actually spell my last name, and you've earned the ability to try. But no, we have pages there for Stack. We have pages for Zeal. If there's questions that people have or things, I've talked with so many pharmacists that are interested in that side of the world. They just don't know where to begin. And I'm happy to try to point people in any directions. I've probably learned more from what I did wrong than what I've done right. I really want to help support people so they don't make the same sorts of mistakes. It's one of those things in healthcare. I think we see it all too often, especially when it comes to patient activity. We don't want you to do any better over here, pharmacy, because you independent, if you do better, then it makes me chain look bad, or vice versa. There's enough to go around for everybody. The more that we as individuals and professionals can help to empower other people to do well, it's only benefits all of us.
Well, Jonathan, I appreciate you joining us. You had a lot going on. You're a busy guy. I appreciate it. The listeners appreciate it. And we thank you for dropping by.
Appreciate you having me. Thanks so much, Mike.
You've been listening to the Business of Pharmacy podcast with me, your host, Mike Kelzer. Please subscribe for all future episodes.